Okay, good evening, everyone. My name is Angela Christ, and I am the director of the Loeys-Dietz Syndrome Foundation and the director of marketing for the Marfan Foundation. And I want to introduce you tonight to the folks who are on this session with us. We have Dominga No also from the marketing team at the Marfan Foundation, who will be hanging out in the chat and adding some extra resources and things as we go along. I don't know, Dominga, did I get you up here?
I'm here.
There she is. Hi, Dominga.
Hi.
We've also got Dr. Rachel Kuchtey, who is our medical presenter tonight. And we have a personal perspective from Tyler Roberts, who will be sharing a little bit later, and will also be on for some Q&A as the session goes on. So, just gotta switch. Before we get started with the presentations, I want to also take a minute to welcome you to week 2 of the International E3 Summit. I know we're coming close to the end of it now. But we are so pleased to have you here. This has all been brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS movement, along with our partners in Europe at VESCERN. Oops. This summit, in case you haven't heard us talking about this in all kinds of different ways, has been truly historic for the Marfan Foundation. This is by far the largest event we have ever been in charge of, with over 2,700 registrants from over 70 countries. And not only do we have people with us from all around the world, but we have all different types of connective tissue conditions who are joining us, including 16 who have registered with Stickler syndrome. So wonderful to have so many on tonight. We have, looks like 10 folks who are joining us as participants so far anyway, to talk specifically about this topic tonight, which is very much just about Stickler. We are also grateful to our partners, our presenting sponsors, Brigham and Women's Hospital and American Communication Construction. I do also want to let you know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or VESCERN. If you hear differences of opinion from speakers and want further clarification, please contact our help center at marfan.org/E3ask. And we do ask for your patience as the volume of questions we're receiving right now is very high, which is wonderful because that's why we're here, is to make sure that members of our community and their caregivers get all the questions that they have answered with the best possible information. So today we are fortunate to have Dr. Rachel Kuchtey present on See the Possibility Stickler Vision Q&A. And we also have Tyler Roberts, who will be sharing a personal perspective after Dr. Kuchtey's presentation. So one last little housekeeping piece before we get started. I would like to remind you that we are very much interested in your feedback on every session you attend, including this one. Below the window where you are viewing this presentation, whether it be through the app or online, there will be a little button that says rate, and you can rate this session in less than a minute, and your feedback is very valuable and helps inform future presentations and education priorities going into and beyond E3. So with that, I'm going to switch modes here real quick and let Dr. Kuchtey and Tyler say hello, introduce themselves. Hang on, I got to stop. And we're going to switch over to here. So Doctor, would you like to start and just say hello and welcome? And then Tyler, you can share a little bit of your own introduction, because we'll probably roll right from one to the other as we get going.
Hi, everyone. Thanks, Angela, for giving me this opportunity. As Angela mentioned, my name is Rachel Kuchtey. I'm with Vanderbilt University Medical Center. I am an ophthalmologist. My subspecialty is glaucoma. I joined the Department of Ophthalmology in 2005, so it has been quite some time. And because of glaucoma, I'm also a cataract surgeon. Both cataract and glaucoma are fairly common ocular complications for Marfan syndrome, for Stickler syndrome, for a whole host of connective tissue diseases. And also because of Vanderbilt Medical Center in the region, and we have a fair large number of patients with connective tissue diseases. So I have a fair number of patients, and I also recently just joined the Professional Advisory Board, and I think that's the reason the board tasked me to give this webinar. So I must say, this is really a great privilege of me. I belong to many medical scientific societies, and this is the most outstanding foundation from the board members, from the patients, from just community, putting everyone together. Look at this. This only day, the second week, and I have attended quite a number of webinars. I think the foundation is outstanding. So kudos, and I hope I won't let you down today. I will try to do my best.
You wouldn't be possible. I've heard your presentation. I know that it is excellent, and I know that everyone on will get a lot out of it. Tyler, would you like to say hello?
Sure. No, I appreciate the opportunity. I'm not a doctor, but I'm a patient. I've been dealing with Stickler syndrome my entire life. My eyes were always watched very closely when I was young, and my problems didn't surface until my senior year of college. So I've had probably 9, 10, 11 eye surgeries all around the United States. I was very blessed to have, good parents that took eyes seriously. This is something that's been seen in my father and my grandfather as well. But as someone who's suffered several detached retinas in both eyes, I'm here to say, as someone that has sticklers, that there is, hope and great doctors out there that specialize in these conditions, which have allowed me to lead a, great life. I've worked on Capitol Hill most of my career. I live and work in Washington, D.C., and I actually got to know the Marfan Foundation just by happenstance when I was up on the Hill doing some congressional outreach. Not on that issue, but as I am one that talks to strangers, I started talking to strangers and happened to make this great connection with the Marfan Foundation. So thank you for thinking of me, and I'm happy to answer patient perspective questions on what I've dealt with, who my doctors are. Dr. Kuchtey, I've actually saw a doctor down in Tennessee, Dr. Stephen Charles in Memphis, that's done some of my surgeries. But yeah, happy to answer questions, and thanks for letting me be part of this evening.
Awesome. So we're going to hand it over to Dr. Kuchtey here in just a second. I want to remind everyone, if you have questions, please drop them in the Q&A inside the Whova app, whether you're in the app or online. Several of them, Dr. Kuchtey has already been in answering, which was very generous. So if you want to take a look at those answers, and if you have other questions you'd like to add to that, feel free to do. We'll be addressing whatever we can or have time to answer at the end. But do put them in that Q&A, because we don't necessarily see them if they go up into the chat. So with that, I am going to turn my video off. We're going to leave everybody, we're going to turn everybody off except for the doctor, and she will, and actually, if you want to grab the screen share, it's the mic and video is yours.
Can you see my slide, Angela?
Yep, there you go. Very good.
Good. All right. All right. Thanks again for this opportunity. I thought, here's the title. We're going to talk about the ocular manifestations of a Stickler syndrome. I thought what I'm going to do is that I'll give you an overview and talk in a little bit of detail in terms of ocular manifestations. The key, what I want you to take away from this is that have enough vocabulary, enough knowledge about this eye condition. Meaning is that you need to be advocate for yourself or for your loved ones. When you go talk to your doctors, know what your doctors are referring to. And some doctors just have no idea even about this eye condition. And you need to be advocate for yourself. I hope this talk will serve that as a purpose, and we'll answer some questions at the end. Let me start out with the genetics of a Stickler. I think it's worth mentioning is even though you're not researchers, I think it's a good idea to have some basic understanding because it is quite confusing. It's still relatively new. Back then, when the classification is largely just based on the clinical manifestations. This is like any other genetic diseases, Marfan syndrome included, Lewis-Dietz syndrome included. The spectrum is very wide in terms of clinical presentations. One family, with different family members, they can present in different ways. So it's better to use genetic classification if you have the gene. So that's why I think it's worth mentioning. In the past, there was another class called the type 3 that has been reclassified for type 1. I throw in Wagner syndrome, and you will see there's a Marshall syndrome as well. So it's quite a bit confusing. So bottom line is that if you just think there are only 4 kinds genetically, type 1, 2 are both autosomal dominant, transmitted in that fashion, meaning that if you have a parent with a disease gene, if that gene, that mutation passed on to you, that you only need 1 copy, you can get the disease. Type 4 and 5 are transmitted in the autosomal recessive fashion. That means that you have to have both copies from mom and dad, and then you have the disease. Type 1 and type 2 are much more common. 4 and 5 are actually very rare, and the descriptions of ocular manifestations are even less so than the systemic manifestations, the papers you can find, published papers. So largely, we're going to concentrate on type 1 and type 2. Among those two, type 1 is much more common, accounts for about close to 80% of all Stickler syndrome patients. Type 2 up to about 20%. And type 1 is caused by the mutations in collagen 2A. And type 2 is caused by the mutations in collagen 11A1. So it's worth remembering, all 4 of them are caused by collagen mutations. Now, some patients have a Marshall syndrome labeled as that. Turns out, Marshall syndrome is caused by the mutations in collagen 11A1 as well. So if you will, you can even genetically put Marshall syndrome to type 2 together. So, based on the clinical manifestations, if you were labeled as a Marshall syndrome patient, now you can draw some information from the studies in type 2 patients to get some ideas. What are the odds of me having a detached retina? There's also Wagner syndrome. Wagner syndrome and is caused by a totally different gene. It's called the CSPG2. That is the gene that encodes the protein called versicine. And that protein is actually a very dominant protein in the vitreous cavity. We talk about this vitreous cavity a little bit more. So it's not surprising they have a Stickler-like syndrome based systemically, both systemically and ocularly. So some patients are labeled as Wagner Stickler, Wagner-Stickler, that I have seen many patients, even during my training almost 20 years ago, Wagner patients, is it Wagner, is it Stickler? So back then, before the gene was known, so you basically lump them together. So now we know it's a different disease. Clinically, it shares some similarities. Turns out, clinically, it's a very heterogeneous group of disease as well. For all these were four types, 1, 2, 4, 5. They have called vitreal retinopathy. Basically, it's a degeneration of a vitreous cavity and retina. That's why you get a detached retina. And some diseases and some types have a much higher prevalence of a detached retina. 4 and 5, even though we know they get a higher rate of a detached retina than general population, but the numbers are in terms of the public. We don't know precisely the true prevalence of those two types. Now, again, clinically, before the genetic factors were known, that as a clinician, especially when you're training, I clearly remember when I was taking the board, studying for board, and I have to just type 1 vitreous is the classic sign is called a membranous vitreous. Type 2 is a beaded vitreous. In reality, the vitreous is difficult to discern. There's just no good way to capture the vitreous. You can argue, oh, this looks membranous to me, that you can argue this looks beaded to me. So clinically, when you classify type 1, type 2, it's just not precise at all. So we do, thankfully now we have the genetic data, and then we can draw the much more information using the genetic data. Wagner syndrome, even though it's caused by a different gene, I think it's still worth mentioning. Systemically, it shares some similarities to Stickler syndrome. But it's the good news about the Wagner syndrome is that even though it's similar to type 1 and type 2 of Stickler syndrome, it's transmitted in an autosomal dominant fashion, but doesn't have as high rate of a detached retina as a typical Stickler patients. They do have a degenerated retina, meaning that their function is just not as good, even though the retina is attached. Such a poor patient, they just don't see well in the dark. So that's Wagner syndrome. In terms of a typical ocular manifestation of a Stickler syndrome, I think is the thing you need to remember is that just like anyone else in the general population, you can get a whole host of the eye conditions, dry eye, you can get the tumor in your eye, you can get the uveitis, all kind of eye diseases. You're not immune just because you're a Stickler patient. So you get, all kind of eye diseases. You need to be aware of this. More importantly, some conditions are much more prevalent in Stickler population than general population, mainly 4 things: myopia, cataract, glaucoma, and detached retina. If you look at those numbers are based on the paper I just pulled out and was published a couple months ago, and it's a review paper. They look at all the publications. Those numbers are not 100% because yes, the classification of the disease, if you look at even old papers, are just not that accurate. But again, it's, gives you some sense that myopia can be as high as 80, even 90% of patients with myopia. And the cataract patients, those are the young patients. Cataract is by and large is old folks disease. When those in the young patient population, you can get as high as 60% of patients would have cataract, even before age 50. Glaucoma, 10%, seemingly is not that high, but if you look at the general population, 2%, 4%, that's overall. And in this population, it can be as high as 10%. probably is even a little bit underestimated for glaucoma. Detached retina is the biggest thing, biggest concern for all patients. I get it. I will show you some slides, and I show you why it is the biggest concern. And also, I want to remind you that the ocular manifestations of Stickler syndrome actually shares many similarities to Marfan patients. I want to just draw this up, bring this up simply because I think there are some health professionals in the audience, and also some patients from the foundation, Marfan Foundation, or maybe some patients suffer from Marfan syndrome. So you're intimately familiar with the ocular features of a Marfan syndrome. So I thought it's worth mentioning this, and I will, show each entity, and I would, use some Marfan features. So just give you some ideas. So now I'm going to concentrate on those 4 conditions. First, myopia. This is the normal eye, schematic of the normal eye. I have to say, the eye is just a beautiful structure. It's very sophisticated, it does many things, and it's also very simple structure, as a matter of fact. If you just look at this, it's basically the light beam. I think I can use my mouse if you can see this. The light beam, the blue is a light beam coming from the right and all the way to the left. This just showing that the eye has very 2 powerful structures, namely cornea and lens. Their job, they maintain clear throughout your life, or during the time that you have the normal function. They need to be clear. They focus the light, they refract the light, and make the light into a very sharp focal point. And the eye has to be in the right size, and this focal point lands right in the middle of the back part of the eye, which is the fovea. That's the sharpest part of your retina. So that's how you see, that's how you get a perfect vision. So this is normal eye, okay? Here we go. This is Stickler eye. Now, the cornea, the lens, maybe they're not so powerful, not as normal as it should be. So you still can focus the light to a focal point here, to a sharp point here. But the main thing is that the eye is so long, much longer than average patients. So that the point, rather than landing on the fovea, it lands right in front of the retina. That's why you get called myopia, meaning that you cannot see far away well without another correction. The way to take care of this is that your eyeball is long, nothing you can do. You're not going to change the shape of the eyeballs. What you do is that put a contact lens on top of cornea, make it a little bit more powerful, or you put the glasses pair of your eye, giving the lens, giving the cornea a little bit more power. Push this focal point, this focus to the fovea so you can see well. So that's how you correct the myopia. Now, here's astigmatism. I'm sure you all heard of this. Similarly, and you have I switched the orientation of the eye here. Again, this is front of the eye. Now you have the light beam going through the cornea, going through the lens, and you focus on the back part of the eye. So rather than making a sharp focal point, the shape can be malformed, not perfect shape. Rather than making a one focal point, you get a bunch of them landing on a different retina. So that's why you have this fuzzy looking E. Your vision is blurry. You just cannot get a very sharp vision. So that's called a cornea, that's called astigmatism. Most of the time, it's caused by the misshaped cornea. You probably hear this, your doctor may give you the analogy of the cornea astigmatism, saying that this is your cornea. It's like a football rather than your typical basketball. So meaning that this meridian is longer than this meridian. Can be corrected with contact lenses, with glasses. So both myopia and astigmatism can be corrected with whatever means you choose. So you may say, what is the big deal? I don't mind wearing glasses, which is as long as I can see, wear contact lenses. It is a big deal to a certain degree. So this is how we classify the severity of a myopia. If you have your nearsighted or your the cross lens, so you have a minus 3 or 6, 4, 5, what have you. The unit is diopter. So we use the -3 as a cutoff. Less than -3, you have a mild myopia. -3 to -6, that's moderate myopia. Greater than -6, that's by definition, that's high myopia or severe myopia. Now, this is actually pretty severe, minus, even moderate myopia. Some patients, they just even mild, let's say -2.75. They just cannot see well. They cannot drive well. -6, without correction, you're not driving. It's not safe to drive on the road at all. So that's a high myopia. For Stickler patients, that degree can be as high as -11, -14. The highest patient I've had so far is -22. So it's a severe high myopia. Again, that you may say, what is a big deal? That's just wear glasses as long as I can be corrected. The big deal is that complications, consequences can occur from just being nearsighted, such as amblyopia, meaning it's a lazy eye. Say if one eye, that Tyler mentioned that he got good parents. Some kids are just not fortunate enough. Say one eye is nearsighted, the other eye is mildly nearsighted. One eye is mildly nearsighted, the other eye is severely nearsighted. Say that's just an example. One eye is -3, the other eye is -9. That difference is pretty big. And when your eyes are still, or your brain is still developing, with -9, you're not seeing well. You get a fuzzy image. Remember the schematic of the eye. And that your brain just tells that eye, forget about it. I'm going to use -3 eye. I'm going to focus using this eye to see. And with time, that -9 eye will never fully develop. And you pass that window of opportunity. Your parents didn't notice that. Toddlers, infants, they don't complain. They have some odd behaviors, but if parents are not observant enough, you pass that window of opportunity to patch the eye, to treat the eye, what have you. By the age of 9, 10, you miss that opportunity. That -9 eye will never develop, will never see well. You still can see, but can never be corrected with the glasses at all. So that's called the lazy eye. Now, you can also have just being very nearsighted, you can have reduced retinal function that can be tested by pathophysiology and electrophysiology testing. And I mentioned that the Wagner patients has a reduced dark adaptation ability. So Stickler patients, they can have that malfunction of the retina as well. Just being nearsighted, -9, you don't have to be -20, -8. You have much higher chance to get a detached retina. Now you get a glaucoma from being nearsighted. You get a macular degeneration as well. I'm sure this is almost like a common vocabulary in general population now. Old folks, they get a macular degeneration, and we do have the treatment. Grandma, 85 years of grandma, comes to us on a monthly basis every 6 weeks to get eye injection to treat the macular degeneration, to prevent it from getting worse, to reduce the chance of further bleeding. As old folks, so we call it age-related macular degeneration. Now, just being nearsighted, you can get a myopic macular degeneration. The manifestation is nearly identical, just at 85 years old grandma's macular degeneration. But the difference, drastic difference, is that those patients that they're 20 years old. So it's pretty severe, the complications being nearsighted. Second is cataract. This is your typical cataract presentation. I'm sure you can appreciate this is the dilated the pupil, and then looking through the pupil is a clear. Now you have this rock hard white, bluish, and yellowish lens. That's because the lens proteins get denatured and becomes cloudy. That's the definition of a cataract. Again, you may ask us, yes, isn't it the old folks' disease? Everyone gets cataract. That's what I tell my patient. Yes, I don't even want them to think if they just come for cataract surgery. I don't even want them to think they got disease. It's just condition, age-related condition. If long enough, you get gray hair, get cataract. That's the nature of the aging change. So when we see the cataract patient complaint affecting the quality of a vision, quality of a life, we go ahead and do the cataract surgery. The way we do it is that we make a tiny clear cornea incision. The incision is made in the cornea, which is avascular tissue. So that's don't get the bleeding. Incision 2.4 millimeter. You put a probe through that incision, get behind the pupil, and you use ultrasound, you use laser energy, and break down the cloudy lens and aspirate it out. And you put an injector which contains the artificial lens. It's just a piece of plastic going through the same incision. You put into this capsular bag to support that artificial lens, and you're done. 5-10 minutes procedure. Is almost instantaneous recovery. You get vision back right away. So it's very easy, very simple. It is truly simple, but it is somewhat special for both Marfan patients and Stickler patients. You notice that this capsular bag supporting the artificial lens is suspended by those small structures on both sides. Those are like ligaments. They are ropey-like ligaments. They're called the zonules. Okay. Now here we go. I'm going to give you another schematic of the eye. Interesting. This line actually just suspended in the middle of the eye by those zonules. Those zonules they are like a rubber bands, and they can relax. They can stretch, and they can change that. Therefore, they can change the shape of your lens. That you can look from far away. You can look, at your desk, and that's because the lens has a minute movement, thanks to the elasticity of those zonules. That's those zonules. Guess what? The predominant is fibroblin 1. It's encoded by FB1 gene. Now it makes sense, right? For FBN1 gene, you have the mutation for mutations. Now that mutation will cause the breakage of the zonules. The zonules are just not stable. They don't have enough elasticity. They break. They don't support the lens. So here we go. This is the patient had a cataract surgery and clear lens. You don't see the cloudy anymore, anything, because the lens is blocked by the iris, which is the orange color in this schematic drawing. And here, 10 years later, this is what you see. The lens becomes dislocated because those zonules, those rubber bands, they just give and you break. The whole lens gets dislocated. So that cataract surgery can be a little tricky. If you were to remove this lens, the zonules are not stable. They tend to break. You can get a whole host of complications. And this is another patient of mine, and sure, this is a Marfan patient, and this is natural eye, doesn't have the cut yet, and you can see one eye. This is the right eye with mild ectopia lentis, and you can see this crescent shape. There's missing zonules here, and this is other eye, the left eye, much more severe. So zonules are missing here. The lens is dislocated. And if this boy, this boy is only 11 years old, if later on he will get a cataract, that's the nature of this disease. If he gets a cataract, the surgery is not your cataract surgery. It's because you don't have that zonules to support. Now, back to the schematic of the cataract surgery. Here we go. This is a cloudy lens. You put artificial lens in the eye. That's how you do the surgery. Again, if you have the zonule breakage, normally the zonules, the capsule, they serve as some like a partition to separate the eye to the front part and the back part. The back part, this orange, yellowish color, that's the vitreous. That's the anomaly in Stickler patients. Those vitreous are not normal. So you don't have the puff. The vitreous is already abnormal to begin with and cause much traction of the vitreous on the retina. That's a setup for detached retina. So we'll talk about the detached retina just a little bit. Now, going back to putting the artificial lens in the physiological position, which is behind the pupil, that's how you normally do the cataract surgery. If you don't have a stable zonules, this apparatus, which is not stable enough, cannot do that. Artificial lens, iris, the color part of the eye, that's not a physiological position. Visually, no big deal. You just have to change the power of the artificial lens, and you still can get a patient to see very well, and they're happy. Their cataract is out, and they got a powerful clear artificial lens. They see well. But again, long term, if you leave this lens in the non-physiological position, that can potentially damage the drainage angle, which is located at the base of the eye. When the drainage is damaged, the pressure can build up. That can cause glaucoma. So that gives us a segue to talk about the glaucoma. That's, again, this is schematic of the eye, and showing here, this is the vitreous cavity. This is the lens. Glaucoma, by definition, is optic nerve damage. That's where the optic nerve is. So the eye would receive the signal from the light signal, changing the photo signal to electrical signal. And those signals would get collected by the optic nerve. And the optic nerve is nothing but a cable, will send the signal, electrical signal, all the way back to the brain. That's how you see, okay? So you have perfect eye, perfect brain, smart brain. If your optic nerve is damaged, you have no connection. You're not gonna be able to see. So optic nerve is a key that can be damaged by a variety of things. But if you have a tumor growing into the optic nerve, you have trauma to the optic nerve, you have MS, you can get damage. The most important fact is the pressure builds up inside the eye. The pressure, intuitively, you can just imagine that can directly damage optic nerve. You get a glaucoma. That's fairly common in Stickler patients, in Marfan patients as well. Now, another challenging aspect for Stickler patient is that if you look at this is, you turn the eye 90 degrees. Here we go, this is optic nerve, okay? And this is the point, this is a close-up of this point, the exit point of the coming out of the eye to the brain. So this is the part. The way the optic nerve exits eye is through this structure called lamina curbosa. This lamina curbosa is like a scaffold. The optic nerve is like a cable made of a huge amount of bundles. In humans, about, say, 1.2 million bundles of those fine fibers. They're called axons, as shown here. When those bundles get out of, they go through this, lamina curbosa is made of connective tissue. Collagen is there and other matrix proteins are there. They have to interact with each other in a very sophisticated way, providing very strong support to those fine fibers. If you have Stickler syndrome, caused by mutations in either collagen type 2 or type 11 or type 9, what have you, you're gonna have a weak support system. Those cables can get damaged without high pressure. So sometimes it can be the double whammy situation. Pressure is high, you have a weak scaffold, and those fibers can get damaged very easily. The end result is what those patients see. They eventually get tunnel vision. You lose your peripheral visual field, and eventually this is all you see. This part, you lose it. The trouble of glaucoma is that it is blinding disease. Once nourished, nothing you can do. Now to reverse the situation, you can only stop the progression. You can slow down the progression, the treatment. You just cannot do the working on it, but we don't weigh to the damage. And it is also a progressive disease. The visual field testing that's fairly commonly performed, the testing within the glaucoma patient for screening, for monitoring, for treating those glaucoma patients. So here showing this is what we do. This is one eye of the same patient demonstrating the progression. And you can see that from A to D. Let's say this is stage 1, 2, 3, 4, classified as mild to severe glaucoma. And this is from the same patient, same eye over the years. Here in A, still normal visual field, you can see there's the black spot. That is the blind spot, physiological blind spot. It's on the left side. You know, this is the left eye. We're testing one eye at a time, okay? So this is blind spot. Other than that, this is a very nice looking normal visual field. As time goes on, you lose a little bit here, and it gets more progressive. Those black spots get bigger, denser, and eventually you get this. And you only have this part left. Now, the challenge is that this cannot be easily recognized by patients. They don't complain. That's why we say glaucoma is a silent thief, steals vision without telling you, and you have no idea. Many patients walk around with visual field like this, even with a stage 4. They have no idea, they don't complain. If the two eye symmetrical, this is the worst eye, I still relatively normal day to day. You don't close one eye at a time. This is only the testing. During the testing, we cover one eye at a time, check one eye, one eye at a time. But day to day, you use both eyes to function. So you don't have any idea, I already lost this amount of visual field. And at that point, sadly, I have to tell my patients, once it's black forever. I cannot change it. The goal is to keep what's white. So that's what patient sees. Eventually, they get tunnel vision, and some patients even lose the central vision completely. And depending upon the degree of the visual field, you still can maintain your 20/20 vision centrally, but by definition, you can be legally blind just based on the amount of the visual field loss. So that's glaucoma. Last thing is detached retina. This is probably the most fearful condition for patients. I get it. Said for other 3 conditions, myopia, cataract, glaucoma, by and large, it's a slow progressive condition. Slowly, you don't have a drastic change. One day you're seeing that, next day you lose vision. Retina detachment can be very drastic. As a matter of a few hours, can be sighted eye and lose your vision entirely. So very drastic change. So that's why it's so fearful. So by definition, the retina detachment, as shown here, again, this is a schematic of the eye, and this yellowish layer is the retina. It's only one part of the retina called the neuronal layer of the retina. Normally, it's firmly attached to the pinkish color, and this color is called retinal pigment epithelium layer. So those 2 layers, they're attached to each other. Not only they're physically attached to each other, functionally, they rely on each other. And I mentioned that the light goes through the cornea, goes through the lens, and actually the light signal gets processed And relying on those cells between the pink part and the neuronal part, they have a very complicated, a very sophisticated changing of the signals that eventually get processed to become the electrical signal, gets collected through the optic nerve and sent it to your brain. That's how you see. But the Stickler patients, the vitreous gel, there is, be it a membranous vitreous, beaded vitreous, or we just call that vitreous syneresis. It's just not normal. And it can cause the traction to the retina. When it causes traction, that can break the retina, tear retina, cause a hole. Sometimes it can be a very giant hole called a giant retina detachment. When you get a hole, the fluid, the abnormal vitreous, can go through the hole and make the separation between the pink part and the yellow part that can detach the retina. Now, this is what we see. When we shine the bright light, I'm sure you can appreciate this as well. So this is a nice looking retina, the pink color right here. And appreciate it right here, it's bullous looking, and you can just imagine the fluid gets accumulated behind this layer. So that's detached the retina. And this is what patients see. You see a curtain, this part of vision is gone, and it move. Doesn't have to be from the top part. I tell my patient, look for the signs. The curtain from the top, from the left, from the right, and that's the sure sign of a detached retina. And you probably notice that those are black spots here, there as well. Those are not the dirt on my screen. Those are the floaters. You see, sometimes I describe that as a bug storm. You see those bugs all over. Now they're just, you're told like a floater here, there, and do I see a fly? Do I see a dust in front of me? And this is no mistake, black flies all over your eyes. So that's a sign of a detached retina. And we can fix it. Tyler mentioned that he had Steve Charles is the greatest retina surgeon. You can surgically put the retina together. You fix it. Again, just like a myopia, you can correct it, but remember the complications of detached retina. You fix it, even though anatomically those two layers are attached to each other, but they can lose function forever. They don't communicate correctly anymore. You're left with this scrotoma. This is normal vision. This is what's after detached retina. Even though anatomically it's fixed, you lose this part of the vision. And later on, you can get a hemorrhage, as shown in this patient. This is the real patient with a detached retina. This is Marfan patient, as a matter of fact. Got a detached retina, anatomically fixed it beautifully. But later on, you get a hemorrhage. And the scar can form, and this part is you're just gonna lose the function. So you can get this kind of, we call it central scrotoma. The part of the vision is just gone. Whatever you do, you have to do the retinal surgery to put the retina back together to the normal anatomical location. You are going to get a cataract, no doubt about it. The cataract can be very severe after the retina detaches. Again, no, someone has a cataract, the cataract surgeon takes it out. But remember, those zonules, they can be abnormal. Not as prevalent as a Marfan patient, but it's not uncommon. You see compromised zonules. So cataract surgery can be challenging. And if you get a detached retina, you have retina detachment surgery, you can get a glaucoma. So a whole host of complications from the just detached retina. It's not just a disease itself, it's a complication. So you need to keep those things in mind. So the goal is to maintain the excellent vision and equal vision in both eyes. You don't want to have lazy eyes. If one eye is lazy, it's going to wander. Cosmetically, that can be very debilitating. So you want to maintain the straight eyes by correcting the lazy eye at the appropriate time. Glaucoma, it is a blinding disease. Nerve is damaged. It's damaged forever. We cannot reverse it. But it's also a treatable disease. The key is to catch it early. Have the patient be aware of this. go to your doctor. You are high-risk patients. If you normally see your eye doctor on a yearly basis because of your high-risk patients, maybe you need to tell your doctor, can I just come in 6 months? It's just that you check on me. So catch the glaucoma early on and treat it appropriately. Detach the retina, warn the patients. You are high-risk patients. Just because you're nearsighted, just because you have Stickler syndrome, you have a high risk to get a detached retina. So for typical macular degeneration patients, we actually give those patients called Amsler grid. We have that paper, have them attached to the refrigerator every morning. You look at the grid and tell your doctor whatever you see is different than yesterday. But for detached retina, if I spot the abnormal vitreous, I always warn my patients, look for 3 signs. Floaters, that's what I showed previously, just a couple slides before. Those dark spots, it's not just, again, few floaters here, there are lots of floaters. Sudden onset, you need to call your doctor right away. Flashing lights, not just a few sparkles here, there. It's constant flashing lights, like Christmas tree. Doesn't matter in the dark or in the bright light. Sudden onset, you need to call your doctor right away. A curtain in front of you, call your doctor right away. Doesn't have to be the combination of those 3 signs. Any signs, knowing you are in the high-risk group, call your doctor 3 in the morning. We see those patients. Sometimes we have to operate on those patients 3 in the morning. So you need to be aware of this. And those are again, the key is to be informed. So that's how you be advocate for yourself, for your loved ones in the family. I think that's the last slide I have. Yep, sure enough, that's the last slide. So I'll stop sharing, Angela, if you.
Yep, and I will switch over to, I'm going to switch over to Tyler. Let me just make sure, actually, share. Just want to make sure I was going to have sound there. Oops. Okay. And now we hear from Tyler.
My name is Tyler Roberts, and I'm 30.
Sorry.
37 years old and live in our nation's capital, Washington, D.C. And I wanted to share my story with you on the impact Stickler syndrome has had in my life. Stickler's has manifested itself mostly in my eyes, but it definitely has impacted other parts of my body, like my joints. And as someone with extensive lattice degeneration in my retinas, I was always watched by eye doctors from a young age. And as someone who has worn glasses since I was 2 years old, my vision has always been something my family and I have sought to protect. So my childhood was uneventful up until my senior year of college. And I started my senior year of college having symptoms of a retinal detachment, something I'd always kind of heard to look out for, flashes and cobweb-like floaters that appeared suddenly. And that was in my right eye. And the vitreous, which is the liquid that makes up your eye in Stickler's patients, is quite different from a normal eye and often pulls oddly on retinas that are predisposed already to weakness. So this progressed very quickly to a retinal detachment, and I went in for emergency surgery. And all seemed great. Over the next couple of weeks as I was healing, I got to go back to college to finish my senior year. It fell over spring break. So I went back to school, and about 3 weeks post-surgery, I suffered what they call a catastrophic giant retinal tear and lost most of my field of vision overnight. Now, I hail from Omaha, Nebraska. I went to college in Chicago, and luckily right in the middle is the University of Iowa. And they were suggested due to them being a research hospital. And again, I had emergency surgery from a very talented physician who was an expert in a lot of the conditions that I'm suffering from with Stickler syndrome and the impacts that I have on my eyes. And I had developed what they call PVR, which is proliferative vitreoretinopathy. And that is a scar tissue that forms membranes on your retina, and that is due to aggressive healing after surgery. And unfortunately, Stickler's patients are predisposed to this condition. And by the time I was able to get in, really about 24 hours after I kind of woken up with lost the field of vision, went to the doctor, rushed me into surgery. My doctor told me that my retina had torn 11 clock hours. So it was almost completely free floating in my right eye. So I went in for, I think it was about 8 hours of surgery. They placed a long-lasting silicone oil in my eye, which is, if you think about it, a hand on wallpaper, which was my retina holding it up. As long as that was in there, my retina was not going to redetach. And then I spent the next 6 weeks healing, having to lie face down. So in my right eye, I've had about four surgeries. And while a lot of my vision was saved, my vision at best in my right eye is about 2200. So the new goal was protect my left eye at all costs. And so about 5 years ago, all was looking good, but another way Stickler's manifests itself in your vision is premature cataracts. And that's something that I did develop, and that came on very rapidly. So I had to have cataract surgery. And with that, cataract surgery can often kind of set the wheels in motion for retinal detachment. And so the same process started in my left eye about 2 years ago. Went to the doctor, started having these symptoms, and he encouraged me to do something that I hadn't done on my right eye, which was to have 360 degrees of prophylactic laser surgery, where they go around and basically tack down your retina with a laser to form scar tissue, different from the PVR that I mentioned about scar tissue, but they scar up your retina as a way to try to just adhere it to your back of your eye as best as possible. And as the doctor was in there doing the lasering, my retina was already starting to detach. So I went in for surgery the next day, took a couple of weeks off work to recuperate, but I'm really pleased that my vision in my left eye 2 years later is 20/20. I do wear glasses, but can also do as I'm doing right now and not wear glasses. So I say none of this to scare people who are listening. I say it so you remain vigilant regarding your eyes. Prompt treatment and a little faith saved my vision, and it can save yours as well. So I would encourage you to find a doctor that specializes in these conditions and stick with them. I'm fortunate that my doctor that did my recent surgeries is about my age, 37, so he is hopefully someone I can age along with and keep going to see him over, hopefully a long life that I have ahead of me. And I know this can be scary, but I say this with there is hope. So if you ever want to talk, if you have any questions, I would always be happy to answer them. I can also share the experts that I've been fortunate to work with and make recommendations of where I would suggest you go and who you see. So thank you for letting me share my story with you all. And again, please reach out if you ever have any questions, you want to share your story. I'm always here to listen. Thanks.
Oops. Okay, so thank you, Tyler, for sharing that. I can only imagine what that has been like for you to have gone through all that.
I do wear glasses. They're just hard on the computer sometimes, so.
I get it. I get it. I'm always like, what? Yeah. So this has been a phenomenal combination of presentations, but I am a little bit aware of time. So I don't want us to run too far over and, not get and get too late into this, but there are a couple of questions that are in here that we might try to address fairly quickly. But if you are moving through and need to sign off yet tonight, I just wanted to, before we do that, remind you, if you have a question and either we weren't able to do it tonight or something comes up later around any topic, not just around this one, please submit your questions to marfan.org/E3ask. As you complete the session tonight, or whenever you happen to be viewing this or any of the sessions in E3, please complete the survey. It really is very helpful to us. We very much value the couple, maybe 30 seconds it would take you to complete it. If you are interested in other services or our sponsors, they are all available in the virtual exhibitor hall. There are some really interesting videos in there and some support things that might actually be really helpful to you and your life or your caregiving around Stickler or any connective tissue condition. If you are not connected in the community in the Whova app or on the website, please do join in the conversation. There's such marvelous discussion and connections being made. And if you're sharing online about this session or any others or your whole experience with E3, we invite you to use our hashtag E3 Summit 20. If you are having a wonderful experience with this event like we are and feel moved to do so, we are always open to donations at marfan.org/donate. It is your support that allows us to continue doing events like these. So I'm going to back up here just a second then, and Dr. Kuchtey, I'm going to toss a couple of questions at you that, and like I mentioned at the top of this discussion, there are some questions in here that the doctor was already very gracious to go in and answer, so I am going to skip those for tonight, but they are in the Q&A and have been answered professionally. So some that are not in, that do not appear to have had an answer yet. Question here, is the red light therapy effective to treat these conditions?
The straightforward answer is that I don't know. If you look at, this is pretty interesting in the internet, that there's some validity to it. If red light may be able to stimulate the energy of the cells, we know that the Stickler patients, they have the hallmark is vitreal retinopathy, is degeneration of the vitreous and the retinal cells. So red light, can that stimulate the health of the cells? That's a theory. Do I have the data? There are some scattered publications for glaucoma, for macular degeneration. I just stumbled upon a site like you can treat anything, basically. The Leber's congenital amaurosis, optic neuropathy, what have you. So I would say at this point, do not try. That's my personal opinion. We don't know, simply because some retina cells, I'll give you an example, the retina degeneration, specific type of mutation caused by rhodopsin. The light can even do the damage to retina. That's known. That has solid clinical data. So I would say, be cautious. Without the large data set, you don't have to rely on 100% rely on prospective study. But without the solid data, I would caution you to take any action. That's a long answer to our quick answer. No, basically, I don't know.
Okay, fair enough. One other question, and then I think we will wrap it up for closing comments from either of you or both. This question says, what about blurry vision, light sensitivity, and migraine aura, especially after surgeries?
Tyler, I'm going to jump in. You probably have a more personal perspective. Anytime you do the surgery, Tyler, you tell me your personal experience. I'm telling you from my patient's experience. Anytime you do surgery, any surgery, straightforward 5 minutes cataract surgery, you will always get inflammation. When you have inflammation, Tyler's situation is even more complicated. His doctor has to inject the silicone oil, gas bubble, you have to face down to a certain position. Inflammation, you get a light sensitivity. You get an ocular migraine, the aura. I'm not entirely sure it's truly related to surgery. It's actually a fairly common condition. We see this, they describe that very vividly, that you see some shape, 15 minutes disappear. I don't think that's truly is related to Stickler syndrome. That goes to back to the first statement I made. Keep in mind, you can get all kind of eye diseases. And those 4 conditions are somewhat more, is much more prevalent in Stickler patients. So I do not think the aura is related to Stickler syndrome, but it's not uncommon that after the surgery, you get sensitivity to the light. You have to treat inflammation. Inflammation can cause a scar formation, can cause the further damage to the retina. So your doctor needs to understand the high risk nature of your condition. Treat inflammation aggressively. Tyler, did I summarize that correctly?
Yeah, I think I've experienced, I had premature cataracts, so I've had cataract surgery, I've had detached retinas. I think, anytime there's instruments or lasers in your eye, you're always going to have, as you said, inflammation. I was always advised by my doctor that, my best vision could still be months away after surgery, as your eye heals. So just to sort of not give up hope, taking the eye patch off the day after that, your body kind of knows what it's doing, and it does take a while to heal. So you might have those, and I'm not a doctor, but those lingering effects from the surgery.
So I realized we didn't have a lot of time for Q&A, but that is, there are some questions in here if either of you would like to go in and add any responses to any of them later. If you are viewing this and would like to see it again, it will be up within, for sure by the beginning of next week. With the holiday weekend in the States, it's hard to exactly say when we're going to get the recording loaded in rather. But it will be available when you click into this session so that you can review it again. Any closing thoughts or additional things either of you would like to add before we wrap it up?
Yeah, I do, but I'll defer to Dr. Kuchtey first if she has anything she wants to say.
I actually just want to echo what Tyler said, that you said beautifully, be aware of those conditions. If it's emergency surgery, have your doctor do it, take care of your eyes, and don't give up the hope. And there's also, we didn't touch upon this, this is a genetic disease. Can we treat the disease in a, a genetic way? So don't give up hope, but do be aware of those conditions. Take care of yourself.
Yeah, I think that's, I definitely agree. And I think to Dr. Kuchtey's points earlier, you're your best advocate. So, do your homework, pay attention to your symptoms. It's something that kind of got away from me when I was younger. And, something that knowing, my vision in my right eye is not great. So keeping my left eye is healthy, get into the doctor. If you need to see the doctor every 6 months or every 3 months, go ahead, especially if you're a high risk patient, and nothing against doctors, but not all doctors are specialized in Stickler syndrome. And I can give a very quick personal story, right as I was having trouble with my left eye years after I'd had trouble with my right eye, I was having the symptoms. I was, getting the floaters, I was getting the flashes, and my doctor had retired and referred me to a different doctor, and that doctor kind of pushed me off. And I came back, and I said, really, this is something we need to pay attention to, pushed me off. And at that point, I took control of my own kind of healthcare, and I sought another doctor that basically took me into surgery a day later. So it's something, nothing against, physicians, but, some physicians don't know about this complicated syndrome with Sticklers. And so just, you want to feel comfortable, trust your gut. If you're not happy, find someone that I think makes you happy. So, I was fortunate, kind of tale of two eyes, but don't give up hope. There's great surgeons like Dr. Kuchtey who really get this condition, get this disease, and can give you your best shot at, the best vision you can get. So, and I'm happy to answer any questions, Angela, if you want to provide my email or anything, happy to answer any questions just about my personal perspectives, but really appreciate the opportunity to speak to everyone tonight.
Tyler, your story is really incredible. And I think, you speak probably more broadly than just in Stickler when you say if it doesn't feel right, if you feel like you know that there needs to be something more that needs more attention, you advocate for yourself, you get another opinion. We hear that repeatedly within the rare conditions community, and I'm so grateful that you followed that instinct and that you were able to find the support you needed, and that you're so willing to share from that experience and from what you've learned with the whole community. So thank you both so much. We will drop Tyler's contact information into the chat here shortly. And so if you want to follow, that stays up even after the session is ended. So you'll be able to check back and get that. And with that, I am going to wrap us up for tonight and just say thank you again to all of you who have attended, who are participating throughout the summit, and most definitely to Dr. Kuchtey and to Tyler. You know, we couldn't do this without experts and kind, generous people like the two of you sharing both from your expertise and your experience. So thank you both so much. This actually wraps up presentation-wise the second week of the summit. So we look forward to seeing all of you throughout next week, our final week of this grand experiment that is the E3 Summit. And I hope that you continue to have a wonderful experience. So thank you so much. Bye-bye.
Good night, everyone.
Thank you.